USC Health. We have a new integrated Center for Clinical Excellence focused on health equity. Today, we'll have about 45 minutes for our community panel. We have a series of experts that will tell us their experience also as well as their opportunities and barriers in their work. So first, if our panelists can introduce themselves and tell us, what does your organization do to advance health equity?
I have been at MUSC for 12 years, but I just moved to Emory University. So I'm not 100% sure what Emory does to address health disparities. It's extremely diverse, so I'm sure there are programs to address it. And at MUSC, I was very fortunate that when I moved in, we already had the group that I do research with already had community engaged group of community members that include Mr. Moultrie to my left. And it's a community partnership that was founded over 20 years ago by Dr. Ida Spruill, who was a nurse from the Gullah community at MUSC. And so we have the opportunity to, from the design of a study, when we have an idea, to meet with the community and get their feedback, or to, when we have results, to help them, to help us interpret the results of research. But personally, that has been what I felt that had the most direct impact on addressing biases and equity in the research we do.
Good afternoon, everyone. I'm Lee Moultrie, a community member, retired now from the Air Force. This is my 30th year being retired. And I'm a part of the Southwest Oncology Group. We'll be coming up, this is the 2025 calendar, so they wanted an old dude to put in there, so they have me there. So as with the Southwest Oncology Group, I was appointed to that board January 2024. I will be on there as a patient advocate for the next 5 years. So as with that, as a prostate cancer survivor, I'm a 9-year prostate cancer survivor. I work with Dr. Marvella Ford with a project at Hale Cancer Center as an ambassador, speaking to African-American men throughout South Carolina relative to prostate cancer. And also one of the committee members, ambassador for the NRDNA project also. And we're doing that throughout South Carolina to make sure that to help African Americans understand the value of participating in that project also. And also in my spare time, I am an ambassador for the American Cancer Society with the Voices for Black Women to help get the message out to Black women to participate in the Voices Project also. So those are a couple of things I do, like I said, in my spare time. I ain't got nothing else to do with my time.
Yeah. Thank you, Lee. I'm Kim Hale with the American Cancer Society, and I'm the Director of State Partnerships. For the American Cancer Society, health equity is not just a department. It's not just a tagline. It's the way that we do our work. And I started my public health career at the health department with our BSEP program called Best Chance Network. And we've always worked to identify, recruit, and encourage Black African-American women to participate in breast and cervical cancer screening. So I feel like I've always been doing this work and so proud of all of the things that we have here in South Carolina. But for ACS, I wrote it down because I didn't want to get it wrong in any way, because it's health equity means that everyone, and we mean everyone, has a fair and just opportunity to prevent, detect, and treat and survive cancer.
Thank you. My name is Mike Lyons. In the program, Rich Steed is supposed to be here. So just to clarify, Rich couldn't unfortunately not make it, so he asked me to substitute. So Rich is the Director of Research. I'm the Director of Clinical Services. I'm a clinical geneticist will giving more of a clinical perspective on the Greenwood Genetics Center. So the Greenwood Genetics Center is a nonprofit institute that is focused on providing clinical genetic services, diagnostic testing, research studies, and education. That's the mission of the Genetics Center, and our vision is to provide those services to everyone who needs them. And so we actually have a precision medicine initiative, so it's a bit more focused on individual patients and primarily with rare diseases. And so we have 4 A's that are our goals for that. One is access to genetics care. One is analysis, making sure everyone gets the right testing, getting answers, and we have functional studies and research to do that, and then taking action with precision treatment based on the genetic cause. And so one example in access, which is where I've been mostly focused, is we've got funding for a project called Genetics Access for All. And in genetics care, part of the problem is there's an increasing demand and a limited workforce. And so we're trying to provide more options beyond the traditional in-person visits with multiple genetics providers and doing more telehealth, which everyone is doing. And that project was focused on providing more asynchronous telehealth options. So those are e-consults, provider to provider, and e-visits, which is patient to provider. And so the e-visits especially, I think, has helped us in terms of providing options that aren't dependent on where someone lives or ability to travel. And even costs are limited in terms of the visits. We're actually doing a lot of those without cost. And so that has allowed us to expand access and also decrease our wait times.
And so we heard some presentations today about community participation, community engagement, and we know that we can't do anything for community, we do with community. Who are the partners that you work with, and how do you foster and maintain that partnership?
Am I going to start each time? So as I alluded to, I'm a member together with Mr. Moultrie of the Sea Island Family Project, Community Advisory Committee. And so to foster our relationships and to make sure our community members are truly partners and that it's not just a shallow, superficial relationship where we just consult with them as needed. We try to have regular meetings. Our goal is to have them quarterly, and we provide breakfast and parking. I always try to include some of our community members who contribute to the research thought project as authors in our paper, since they help us with designing the projects, the goals, and interpreting the results. And also trying to compensate them for their time, which is difficult because when we propose grants and need to budget for funds as consultants, there are no established structure or means to distinguish between a commercial consultant who provide a fee for service and the fact that our community members are already from groups that have been underrepresented and stigmatized in research. And I wish we could have other means of compensating them than just this transactional payment for their fees. And I wish that institutions had more means of providing services like access to care that the communities actually need. So we've tried to advocate. Apparently, the only thing we can do is use foundation money for that. But we just keep trying to working together and do what we can to show that we really value and we want to be as true collaborators in research.
So with me, as I shared, I retired from the Air Force 30 years ago. My profession in the Air Force was logistics management. Everything dealing with transportation from water, truck, rail, air, hazardous material, classified material. I have no medical background at all. I became aware of the medical community when I was in the barbershop, like 1999. Saw a bag that said, you want to learn about prostate cancer. I called the guy up. He was doing a project out of MUSC. And we had a 30-minute conversation. He said, if you want more information, come by my house. Went by there. We had a 3-hour conversation. And now it's 25 years later. That's it. And so I've worked in so many different areas within the healthcare arena. And being a business owner, what I've learned and what navigating these systems is that I establish relationships before I need a relationship. I don't come asking the medical university, give me money, give me this. I know how important it is as a community member to be at the table to get access to resources that various communities can use at various times. Makes no difference what ethnic background they are, what gender they are, getting access to that information and making sure that they get the information they can share with other individuals. Organizations that I'm a non-traditional community engager. So you might find me in a nightclub. Dr. Chanus, he asked me, when's the last time you've been in the club, Mr. Moultrie? So I just did a Making Stride American Cancer Society project in the on the nightclub probably about a month ago. I was there, had a table there, educational information. Hey, old dude rock, okay? I just did a veterans meeting last Sunday. I can go to different churches. Pastors invite me to the church and they say, hey, this is Mr. Moultrie. He's going to talk to you about this disease or that disease right there. I did a television interview, local television interview 2 days ago. Do podcasts, Facebook Live, YouTube, business networking session, elected officials, be it local, state, national. I might be in Washington, D.C. with American Cancer Can, ACS Can, and I've been up in D.C. for the past 24 years, them, be it zero cancer, whatever it is. Also in the barbershop, cosmetology, all of these different things that I find it important because I am sharing with the community. We have access to this information. We have access to these professionals. Whatever question you need, we can go to the professional and ask that question. And so what I'm doing is moving whoever may be somewhat of a gatekeeper, we go by that person because I'm sitting with the MD, the PhD, and whomever it is. And that's between MUSC, Medical University of South Carolina, University of South Carolina, Roper Hospital, the VA hospital. I sit at all these different tables, and it's nationally also in different groups also. So it's important. So often I hear individuals say, I can't get a seat at the table. Well, I'm concerned with that statement because sometimes you might be invited as a community member to be at the table. There might be an article in the newspaper about we need volunteers to participate here, then you can be there. Or you might have to pay to be at the table. I'm a member of the U.S. Chamber of Commerce. It costs me to be a member of that organization, but I'm there to get access to that information to disseminate it throughout the community on the local, state, and national level also, regional also. So those are a couple of things.
Yeah, just a couple of things. So, I partner with people like him. But one thing that you said that was so important, you go to where people are.
Yeah.
You have to do that. And so when you're thinking about putting together a public health campaign or a study or promoting whatever, you have to go to where the people are. And they have to recognize your face before you show up to announce whatever. Right? Like he said, is so important. For me, for the American Cancer Society and the work that I do, I have found the best way to approach my work is to have clinical champions. I go to the South Carolina Primary Healthcare Association. Next week, I'll be at the Rural Health conference in Greenville. I go, I listen, I learn, I hear about what others are doing and where from the cancer lens, I may be of help or an asset or to know where to go for whatever the need may be in the community, and to be a convener. I think that that's where I've gotten in my 30 years in public health, is where I can facilitate and convene folks to meet needs, to be a solution-driven advocate. So that's one really great way to approach work in this field. Also, survivors. When you work with survivors of whatever chronic disease that you're wanting to work with, you get a passionate individual who wants to help others prevent or detect as early as possible what they have gone through. And so you get a dedication and a personal buy-in from someone who you're not going to get from the average person in the community, because until you've walked that walk or been in that diagnosis chair, you really cannot, you can have sympathy, but you cannot have empathy like that individual can. And I think finding someone who is able, at the state of their disease, to be able to share and advocate, go to DC through the Cancer Action Network, our sister company with the American Cancer Study, and be that voice. So finding those individuals that you can partner with is absolutely key to any of your work that you're going to do. And then several people have mentioned throughout the morning sessions, do you partner with FQHCs? And I say absolutely, because one of the things that I do and always want to do with anything that I put my name attached to is to help people find a medical home, whether it be an FQHC or a community health center or a free medical clinic. We can't come in with a grant-funded program for a year or 2 years and then walk away and say, good luck. You really, to get, to have a true relationship and to get trust, you really have to be there for folks and to get them connected to medical care. And one of the best ways that I've personally done that is through our FQHC program and centers across the state. So I think that's where I would say I collaborate the best.
So our main partner and collaborator is really the state of South Carolina. So this is our 50th anniversary, and we were founded in October 1974, largely with support from the state of South Carolina and specifically the Department of Disabilities and Special Needs. That's been our primary partner for 50 years, and that continues to be a strong relationships where they provide funding for us to provide services for patients across South Carolina. We do have 5 offices, our main campus in Greenwood, and then we have satellite offices in Greenville and Columbia, Florence, and here in Charleston. And so that allows us to have, scope across the state, but we are still relatively small. We have about 200 employees compared to large healthcare systems. So we do have to partner and collaborate and work with all the healthcare institutions and hospitals across the state. That includes Clemson, so not necessarily patient-oriented, but a healthcare in terms of, interest in precision health. And we're talking to them more about that. They actually have the Center for Human Genetics at our campus in Greenwood. So the Clemson Center for Human Genetics is on our campus. And so Rich, Steve, who is going to be on this panel, works very closely with that group in terms of promoting research into primarily rare diseases. But our most recent partnership is with MUSC and really, again, trying to use our strengths as a relatively small organization, very focused on genetics, and MUSC's strengths and all the resources and personnel and areas of healthcare, and trying to infuse genetics and precision health across different healthcare institutions. That's a really important, vital partnership where we're working together to provide services for everyone across the state.
So the next is a 2-part question. Have you participated in precision health research? And also, what are some of the individual barriers that you think people have to participating in this research?
It's not always explicit that the study is precision medicine research. But typically, the goals, if a study collects genetic data and social data and electronic medical record data. The goal is to be able to develop tailored interventions or treatments. So I'm not sure what the second part was.
What are some barriers?
Oh, so there's barriers at all levels. I really love that Dr. Allen presented that paper from Galasso that was published this year, because she mentioned the upstream barriers, and then there are the downstream barriers to people actually being able to access the benefits and the treatments from precision medicine, from costs to distance. But a lot of the upstream barriers, people usually talk about studies not including people of all backgrounds for either direct or objective reasons like distance or cost or time, to more subjective things like mistrust in the system. For me, there's also it was the main hesitation I had, were the legal barriers and the privacy and discrimination barriers. So it's not totally clear that there are protections in place for how genetic data might be used. The data privacy issue, it's not always clear that data privacy can be confined or it can be totally kept private. What led me to participate was that as a geneticist, I actually saw the leaders from the Helix project. So many genetic companies actually sell the genetic data, and genetic data linked to personal data and electronic record data can be sold for like $20,000 per person. So I didn't want to contribute to a company that could do whatever they want with my data, and that in the end can be used for like behavioral research. It could be really stigmatized for certain groups because it does not take into account the environment and factors, traits that are basically non-genetic, and people trying to attribute genetic causes for them. But so I was reassured that the data from Helix was not sold to other companies, and that I, at the human genetics meeting, could see some of their leaders attending sessions on privacy of data and equity and diversity. So that reassured me that there were protections in place to protect our data, and the fact that MUSC created the Research Governance Committee to ensure that beyond what HIPAA does, and HIPAA by law is only, not HIPAA, the IRB by law is only concerned with harms that can happen to individuals. So they're not concerned with harms that can happen to community or groups, but the fact that in our DNASC at MUSC had the vision to create a Research Governance Committee to ensure that any research done with participants' data is transparent, is publicly available, and it won't be used for stigmatizing purposes. So that's what gave me reassurance and what removed my barriers to participation.
Most of the things that I do in the community are nationally. When I'm speaking with Dr. Allen, when we're speaking about the NRDNA project, what I'm asking folks to do before I come and speak somewhere is Google my name, see some of the things that I've accomplished, and understand, one, with me participating in Desert Shield, Desert Storm in the mountaintops of Saudi Arabia, me being a civil rights activist, being a lead plaintiff on a case to go to the U.S. Supreme Court in 2004 against the county we are in now that impacted over 360,000 people. And as an African-American man, to participate in the Million Man March in 1995, I think it was, Washington, D.C., and so many other things. So in the faith community, being in the faith community for the past 36 years. So being able to speak the different languages of different communities all the time, when I'm going in there, then they're like, oh, okay, and I'm a native of Charleston also. So that makes it a little bit different when I'm speaking to them of any project. So anyone that I'm partnering with, they have that added credibility right there. That's what I'm doing. Whatever project it is, as long as I'm sitting there, is making sure. Now, do you need to know that I'm a civil rights activist? You don't need to know that. When I'm in a community meeting, I'm not saying anything. When I'm at MUSC at a different meeting, no one needs to know that. But I'm saying that we want to make sure that people understand we are not, we're working to make sure that discrimination, alienation, or anything else is not going on. So that's what I bring to the table with the partners that I have, no matter what project we're working on. Be it one of the projects, I'm an ambassador with a project out of Boston, Prostate Health Education Network, one out of Jacksonville, Florida, the Proton Therapy Center there. So if someone calls me and say, hey, I have this treatment, what can I do? Who do I speak to? Now you're saying what project has been successful? Well, I'm working on a project now with Dr. Marvella Ford, and it's called the South Carolina AMAN Project. What that is a training program for African-American men relative to prostate health. Because what I'm trying to get the whole system to change that language of prostate cancer. Because all men in here have a healthy prostate until cancer comes upon them, right? Okay, that's what we want to do. Now, I want to read a statement from Dr. Jesse Mills. And his statement is this, right? Jesse Mills, he is the creator of the UCLA Men's Health Center, and he's a consultant to the Lakers and the Dodgers. And he says this right here. I found this so profound. I don't preach to my patients. I dialogue. I tell the men who see me in my office that we'll be spending only 45 minutes a year together. So the remaining 364 days, 23 hours, and 15 minutes are up to them. And I would venture to say this is applicable to women also. So when you're speaking to your provider is saying this. Now, we are educating men on treatment options and other things. We just got a report. Recent report, prostate cancer treatments carry substantial long-term risk. A new study finds that medical guidelines do not provide enough information on these risks to help patients make informed decisions. This is 2024. Dr. Ford has been educating men in South Carolina with this project for a number of years. I don't know how long. And they decided to find some old dude and put on his back and push it, you know. So they got me on my back step right there too. So it's important. I sent this report to one of my associates who's a prostate cancer survivor. He says, Lee, I'm living what this report says, which is bad. Because what it's saying is that most men, because they don't have enough information when they're making a decision on treatment, they have problems with erectile dysfunction and incontinence. The majority of men, right now, this is what's happening. And this guy said, this is what I'm living through. So he says, my doctor needs to know this right here. I said, no, you don't. My contention is all of us in here need to know as much about our body, our health care, than as much as your doctor. Because when I had my treatment, I was diagnosed in 2015. I didn't have treatment until 2021. It's called watchful waiting, if some people didn't know that. Most people say, oh my God, health disparities, you could have died. Yeah, you can die of many things. So It's active surveillance, watchful waiting. If it's a slow growing cancer, you can do that. So many people are rushing to have treatment. How does all of this play? We want to make sure that individuals have enough questions to ask their provider. And if you're not getting adequate support from your provider and you're not happy, you do what I did. I fired my doctor. He did not have enough information for me. He didn't give me my treatment, all of my treatment options. I found out about another treatment option that he didn't bring to my attention. I terminated that relationship with him and went to Jacksonville, Florida, and lived there for 2 months. It's nothing personal. It's my life. It is your life and your family's lives. So we must investigate whatever treatment options that they're giving you for whatever disease that may be. You can investigate it. So please do that. And now, last thing, the health community says to patients, you must advocate for yourself. And I said, that's concerning because the health community has not educated the practitioner how to do that. I said, so now health literacy has thing Ask Me 3. So I would ask anyone in the medical profession, what is my main problem? What do I need to do? Why is this important for me to do this? That's anyone in that chain of your health care. We have to educate patients. These are some basic health literacy information. 2008, I was featured on a calendar for Aetna, and the calendar was, the theme was health literacy, a dose of understanding. So we have to educate our society. The whole society. They know more about football, basketball, and everything else than their own body. So we have to change this way we do system. So you know me, I'm the shy and introverted one up here.
Yeah.
I think the only thing to add that I can think of is, overcoming barriers to getting clients to sign up for programs or precision medicine or behavioral health study is that you really have to get buy-in. And I find the best way to do that is have simple, straightforward facts. People want to know the facts. And so go with data in a very simplistic way that you can make your point and why they need to participate. So simple elevator speech, why you're doing what you're doing. My speech for the voices of Black women is South Carolina is doing a fantastic job screening women. We're actually screening Black African American at a higher rate than white Caucasian women, but more are dying of breast cancer. So where is the disparity coming from? From screening to death. We have to find out why, and I want you to participate in the study so that we can get the answers. So that's the why, so that the next generation can have better health outcomes.
So for the Greenwood Genetics Center, our focus is on rare diseases. And so, it's trying to, again, talking about our 4 A's, get access in order to take action ultimately and find treatments for patients who otherwise don't have really any options. And so we have been able to participate in some larger clinical trials that are sponsored by pharmaceutical companies. So some of the recent ones include Rett syndrome, where there's a recently FDA-approved drug, and we were a site for that. So, and then Fragile X syndrome is another area where we're involved in those kind of trials. And those are great, and it's great to be involved in those. The reality is if we didn't participate, someone else would. So what I'm tend to be more focused on are the patients with rare disease that have no trials, and there is no interest. There's only 10 patients in the world. And so we're seeing them diagnosing those patients. So how do we help them? How do we help that family, who are as desperate as any other to get treatment for their patient or their child? And so we have developed a genomic discovery program where we are focused on these 4 A's and finding the answers. And by finding the answer to a specific for a specific patient, we can then tailor a particular treatment. It's not so much the gene therapy that I'm sure everybody hears about. All the gene therapy is super exciting, very, very expensive that are coming out. So these are more on looking at supplements or repurposing drugs that are available, more easily translatable. We don't have the capacity to develop a new gene therapy, but the thing that we're seeing while we're doing this is that if we understand the gene and the mechanism, we can utilize a supplement for one patient with a particular genetic variant, but that can translate for maybe 10 other patients with other genes because it's a similar mechanism. And so the biggest barrier is identifying the patients, and kind of mentioned earlier that, you know, we see patients who are referred to us, but that's the tip of the iceberg of those who have genetic conditions. Even rare genetic diseases where you would think they would have been referred to a genetics clinic are not often referred. And so that's the biggest barrier, is getting access and utilizing, going beyond genetics clinics, you know, getting into all the healthcare systems, identifying, you know, patients who would benefit from genetic testing, getting them the testing that they need, then finding potential treatments.
Can I throw one other point? It's a thing I'm tossing in my head recently within the African American community, our society as a whole, the African American community I'm communicating with, is that I'm thinking that some in the African American field, if I'm not at the table, you need me. And then I say to them, we don't know you exist. Because if you're not here, how do I know how to communicate with you? You're not telling me anything. But if you're not participating in the study we did there or any other studies we're doing, we don't know you exist. Be it the church, be it the sorority, be it the veterans group, whomever it is. And I speak to them relative to premature death. And I'm like, do you know what age is premature death? They don't know. 75. You die before then, we're concerned. We're upset. Because we didn't do something we could have done to help you live longer. So the thing is getting people to understand they have to be at the table to voice their concern. What do you feel is a barrier? How do we address this? Do I bring you to Dr. Allen? I mean, we had someone that had some concern, and I got them on the phone with Dr. Allen. They said, well, I saw you on the local television talking about the DNA program, and I was just concerned. I said, what was your concern? They said, so. I said, well, let me get Dr. Allen on the phone, and then you can do a discussion with her relative to the study. But the person said that because he recognized me on the television being with the study, and I said, okay, let me get you to the project officer, and then she'll be able to help you. He was happy. And that's what happens even when we did an editorial a couple of years ago in the Post local newspaper. When I did it, the people read it and they said, oh my God, yes, sir, you're speaking the right language. So again, when they recognize the name, they're able to make a call to someone or send me an email and say, how do we get more information? So you have to be out there. But the community has to be responsive, whether it's African American, whether it's white, whether it's Latino, you have to be engaged to say what is a barrier, a preconceived barrier, say that, and then we address it. That's our responsibility.
Thank you. And from all of your years of expertise, what is one way we can increase representation and access for underrepresented groups? And then secondly, what can the audience do to get involved?
Mentioned that we have the American Cancer Society has partnered with Emory University. We have the Voices of Black Women study. It's going to be a 30-year behavioral health study to identify, is the hope, to find out the causes for many of these diseases. We're recruiting participants from the age of 25 to 55 who have not had a cancer diagnosis. So if you want to find out more, you can go on cancer.org, our website, and look. We have all the information there, and we would love for you to share this information because we really are trying to recruit 3,000 women from South Carolina so that we can get our South Carolinians' voices heard.
I would say that, yeah, reach out to whatever foundation, association, if our interest is in a specific disease or trait, just there's like non-profit associations for basically any like rare disease or common disease, from diabetes to, I don't know, Tay-Sachs disease. So usually these foundations are, or associations are, the best way to be the bridge between that community and the research and the medical system. At the same time, I'd have to say I kind of slightly disagree that we, or at least that we need to put the sole responsibility on the communities for being engaged, because many people just don't have the resources and the infrastructure to access research, to access medical centers, to be in touch with these associations and foundations. So many people, because of historical discrimination, just don't have the electronic resources, the financial resources, don't have the time. We have so many patients who cannot even drive to their medical appointments here because it's 4 hours and they need to find someone to drive them, and a single mom who works 2 jobs just will end up probably dying because she cannot come to her appointment. So it's, I don't feel we can totally blame the communities that for historical reasons have just been ostracized out of, main society and access to resources and education that we have now. So I think it's also up to us to try to reach out and bring that information. And I would say, yes, again, leaning on associations and foundations whose main role is to build that connection is probably our best way.
Just from the perspective of, from a rare disease, foundations are incredibly important and valuable. They tend to be focused on individual diseases. And so there are some that are really robust and have been around for a long time, and they're well known, like Fragile X syndrome as an example. But then again, we see a lot of conditions that it may be 1 of 10 patients in the world that's recognized, and there is no foundation. And we tend to see a lot of the time when we make those diagnoses, or at least in some of the cases, the parents are the ones who are the champions. They develop this foundation, and some of the foundations are really amazing how quickly and robust those are based purely on parents, moving forward. And they're the ones reaching out to researchers, and there's the ones who are driving. There's one I've been involved in recently, and within 2 years of the foundation, they already have a gene therapy like in development and ready to go, and part of it was that the mom in that case happened to be a PhD researcher. And so she had this background and she had the initiative too, which is key. But we see that in a lot of cases, and that's great and that's fantastic, but we don't see it for all of them, right? And so then you still have these rare diseases where we have patients and there is no foundation, and it's hard to point them in the right direction. And we try to, provide as much support and advocacy as we can. And we try to encourage them even to look at that and look at this other foundation, and maybe you can get involved. And a lot of times that helps. And that is one thing that I've noticed, over 20 years, is I'm not a huge fan of social media in a lot of cases, but that can be really helpful, like Facebook, for example, with these families where they connect to other families with rare diseases across the world. And so that's been a huge benefit for families and connecting and community connection.
One thing with me, I celebrated my 68th birthday in September. And so on this journey, I have to do things differently when I communicate with folks. And as you're saying, the holding people accountable, not holding them accountable. I was a part of an organization called the 100 Black Men of America. Very large African-American group, mostly professionals, and they let a little thug like me step in there. So when I get there, I'm sitting on the National Health and Wellness Committee, because I'm speaking to them relative to tobacco being hazardous within the African-American community. Saying, this is what's going on. And they said, whatever you bring us, that's what we want to know. And I think that was probably like 2002, 4, something to that degree. And then a couple of years later, we set up an initiative called Set to Date. So the wives would set up the appointment for men to go to doctors. And these guys are professionals. I'm saying these are attorneys, doctors, PhDs, MDs, and all the stuff like that, business owners. These guys are so intellectual. They would call the doctor and cancel the damn appointment. Did you hear me? These intellectual guys would call the doctor and cancel the appointment. Now I have fraternities, sororities in the African-American community. Hey guys, what are you doing? Let's do this, let's do it. Mr. Moultrie, we don't do that type of work. My job within the African-American community is to hold these guys accountable to do what they're supposed to do. If you're a minister, do what you're supposed to do, protect your community, bring the resources. If they need to sit to the table, be at the table. I make sure that they get invitations everywhere they need to go. I'm not going to have you sitting there and say the institution may not be as receptive to African Americans, may not be as receptive to Hispanics or whatever it is. What is the concern you have? Bring it to me and we address it. Because we have to change. I mean, you can play the game of racism, and someone brought it up in Dr. Allen's presentation earlier in the year relative to some of the disparities on the Tuskegee experiment, and you have to be careful with African Americans, and I shared, at that time I shared with them, we cannot continue holding the healthcare system hostage to injustices that happened in the past. We must be aware, but we can't hold it hostage. No one in this room, anyone online, did not get in healthcare to do injustices. More than anything else, all of us are the watchkeepers. If we see something that's wrong, we're the one that's going to call it out. So we have to look at things different. We have to do things different. And for what God has blessed me to be able to do within this society for the past 68 years, I can go to any leaders in the African-American community and say, we would like to have you at the table. Now, whether they decide to come or not, that's on them. That's why I'm in the nightclub. That's why I'm in the barbershop. That's why I'm in the cosmetology school. No, I don't dress like this. I have to be dressed different in these different environments. But it's about having fun. I enjoy exposing individuals to different information, resources that they can achieve a goal, live an optimum life to 100+ years old. Who's familiar with the Blue Zone? Okay, so we're familiar with the Blue Zone. Why not tell the patient, you know, you can live to be 100 years old and older and in good health? When we talk to Dr. Tia, when we talk about longevity. So if I can learn this as a non-degreed person, anyone else can learn the same information. So those barriers that they throw up, I say, no, those don't work. How did I catch my cancer early? Because I was screened from 39 years old to 59 when I was diagnosed. I just listened to the doctor. I read it in the newspaper, and it says, oh, you can come get screened. So the community is the same way. So we can't say that an institution, be it in North Carolina, South Carolina, Georgia, wherever, has this barrier and we still have to go along with it. No, we go in and address that. That's all it is. That's all I do. So it's an enjoyment, because what we want to do is help people live a full, healthy life. And with the new administration we have now, we're going to be working to be more inclusive. That's the language we have to use for the new administration. So we're gonna have to frame our language a little differently to coexist and to still provide quality health care to everyone. That's it.
We have about 5 minutes. What questions can the audience propose for our panel? Yes.
Hi, thank you everyone for all the talks and stories you've told us today. I just had a quick question on what have you found to be the most effective recruitment strategy in the work that you do? So along with my work with education materials and getting it out into the community, I try to be at events and make myself shown and so people see my face and recognize me. But what are other ways that maybe could help, increase that reach within any community really?
We have used, actually, Jacob presented earlier, is that